Okay, number 3. So what I've decided to do, voice break right at the start, fantastic. Some of these I'm going to have kind of as a systems one. There's going to be ones that are just kind of like a jumble depending on what questions I can find. But today we're going to only be covering the respiratory system, and that'll be reflected in the title. I have also figured out how to get my mouse showing, fantastic. And to try and expedite the process a little bit, I've actually put the pictures over here and dragged them across. So hopefully this one will be a bit quicker. Right, question 21. Normal expiration is a passive process during which no muscles are active, such that the lungs return to its functional residual capacity. Which lung condition could transform expiration into an active process? Is it chronic bronchitis, acute cough, emphysema, pulmonary fibrosis, or asthma? So during inspiration, the diaphragm contracts and flattens downwards, and the external intercostal muscles, so those are the ones between the ribs, these contract and lift the rib cage up. Those are the main ones active, and in fact it's usually only the diaphragm that is active during quiet inspiration most of the time, with more of the muscles getting involved as inspiration becomes more forceful. So in addition, just so you have a full range of it all, you've got the sternocoid mastoid muscles on the side of the neck, and that helps to lift the sternum and clavicle up. You've got the scalene muscles, which help to lift the first two ribs. And then you have the pectoralis minor muscles, and that also helps to elevate the rib cage. So think of the lungs like a balloon, because they kind of are. If you have a balloon in your hand, it's not going to inflate by itself. You need to blow hard to force air into it. And in the case of the body, well, actually, I guess a good way of saying it is that if you have the air fully inflated and then you let go, like you're holding it with your finger and your thumb, and then you let go, it's all going to just come out naturally because it wants to equalize. And this is kind of the same to how it works in the body. So the way that air is brought into the lungs is by creating negative pressure within the thoracic cavity. So by expanding the lungs, the same amount of particles that filled the lungs previously now occupy more space. So this negative pressure creates a vacuum, which now pulls air from the atmosphere down your nose and into the lungs. So this is why expiration is a passive process. If the diaphragm and all the associated muscles naturally relax, the pressure on the inside of your lungs will want to equilibrize with the pressure outside the lungs. So air almost escapes almost by itself, really. So disease that's going to affect this or affect the difficulty of gaseous exchange is going to turn this into an active process, particularly obstructive types of diseases. So let's go through the ones that are possible answers. So with this one, oh my goodness, this one isn't even chronic bronchitis. Gordon Bennett, right, okay. So chronic bronchitis is one of the two main conditions of chronic obstructive pulmonary disease. Chronic bronchitis leads to inflammation and increased mucus production of the bronchioles in the airways. A combination of both of these factors leads to the airway becoming more narrow, which makes it more difficult for air to flow in and out of the lungs freely. Does this turn expiration into an active process? No, and we'll come on to that in just a second. Next, we have an acute cough. So acute cough is not a specific lung condition. It's a symptom which may be related to one of several underlying causes, really. Maybe it's an infection, allergy. It could be the byproduct of certain ACE inhibitor interactions. So the process of coughing, so yeah, that's going to exhale air from your lungs. That is an active process, but even if you have a cough, the normal process in that tidal volume is not going to be transformed into an active process. It might seem like a semantic argument, but it is important. Next, we have asthma. So asthma occurs periodically, and you get the bronchoconstriction, which again is going to make it more difficult for air to pass in and out of the lungs. Again, this does not turn expiration into an active process. One, it's intermittent, so this is only during asthmatic attacks, but there's also another reason why it's not doing that. And again, we'll talk about that in just a second. Next, we have pulmonary fibrosis. So pulmonary fibrosis is characterized by the scarring of lung tissue. Fibrosis literally means the thickening or scarring of tissue. This reduces lung function by reducing the lung's ability to expand and contract. This is a possible candidate, but again, remember, it's a single best answer. So, I mean, I've kind of given it away a little bit, haven't I? The correct answer to this would be emphysema. So in emphysema, the lung tissues become damaged, particularly the alveoli, and those are the ones responsible for gas exchange. The reason why it's emphysema and not the others is because this damage leads to the loss of elasticity in the lung tissue, and this makes it difficult for the lungs to recoil during expiration. So again, the pulmonary fibrosis, the scarring, it can reduce some lung function, but it tends not to reduce this lung elasticity. So again, with that balloon analogy I was saying before, the air escapes almost by itself. The lungs just need to recoil back. And so a disease that's going to prevent that, how do I put this to a balloon analogy? If you blew up a balloon and somehow managed to put like paper mache on the inside, I don't know how you'd manage that, and kept the air in and waited for it to dry, when you then let go with like the finger and the thumb, because there's that no longer the elasticity involved in that balloon, the air isn't going to escape because the paper mache is now keeping it open. And the same kind of works with the lungs, is that there's some kind of process, in this case emphysema, that's going to reduce the elasticity. You're now going to need to actually use some of those accessory muscles to actually push the air out, because it's not escaping naturally. So the lungs lose their elasticity, and this turns expiration, it makes it more and more difficult, and it slowly turns it into an active process. Sometimes when the accessory muscles are required to force the air out of the lungs, it's known as hyperinflation, and this is something that's quite characteristic of emphysema. The lungs can become overinflated, and they're unable to effectively expel air during the expiration process. So yeah, the key difference between this disease and the others is that loss of elastic recoil. The other diseases don't impair that. So if we go back to our questions, so it's not chronic bronchitis or acute cough, and it's not pulmonary fibrosis or asthma. It is emphysema because it causes this issue with the elastic recoil. I've said elastic recoil so many times now, it doesn't seem to mean anything in my head. Right, question 22. Bronchioles in the lung can be divided into primary, intermediate, and terminal bronchioles. Which bronchioles exhibit the greatest and least total resistance, respectively? So is intermediate and primary, terminal and primary, primary and terminal, intermediate and terminal, or terminal and intermediate? So we'll just have this lovely little diagram here. So in this diagram, the intermediate bronchioles it was referring to are now referred to as secondary bronchioles. So, yes, I have a mouse now. So you have the trachea, comes down into the primary, and then this kind of branches off into these secondary ones here. And then these secondary ones further branch off, and then you get all of these tertiary ones. Okay, so the primary bronchioles, as you can see, have the largest diameter, and the tertiary ones have the smallest diameter. So at a glance, that would make you assume, the primary bronchioles have the least resistance, and tertiary bronchioles have the most. But diameter is only part of the story. So to understand resistance, we need to look at Ohm's law, something that physicists and engineers should be quite familiar with. In the context of the lungs, we're going to be using this equation here, where in this R stands for resistance, this little triangle over P, the little triangle I'm sure there's a specific name for it, but the triangle stands for the change. So triangle P is the pressure difference across the structure, or the change in pressure. And then the Q is the flow rate through the structure. So we need to take all of that into account. So the primary bronchioles have the largest diameter, yes, but the terminal bronchioles are actually the ones that offer the least airway resistance. And this is simply because there's more of them, and you can see there's loads of them. So because there's more of them, the total cumulative cross-sectional area is greater just from the sheer amount of them. Secondary bronchioles have a smaller diameter than primary bronchioles, and whilst there are more of them, you got, you know, one here and one here, there's not nearly as abundant as tertiary ones. So these secondary ones end up having the smallest cumulative area, and that's what's important with resistance, the cumulative area of all of them together. So as a result of this, resistance is greatest at the secondary intermediate bronchioles. And this is quite important when you're doing pathology of the lungs, because this is when it's kind of like the rate limiting step. Because there's the greatest resistance here, something going wrong with the secondary bronchioles is going to have the greatest impact on the rest of it. But if we go through all of them from most resistant to least resistant, most is intermediate, moderate would be the primary, and then least are the tertiary bronchioles. So just make sure we write this right. So the greatest resistance is going to be the intermediate, and the least is the terminals, and that will be our correct answer. Make sure you read that, because I have accidentally answered a question wrong. Well, I knew the answer, and then I just read the answer wrong, clicked the wrong thing. Don't do that. Don't be an idiot like me. Right, question 23. So mucus and cilia help protect the respiratory system by trapping pathogens and by wafting the mucus upward so it can subsequently be swallowed, respectively. In which area of the respiratory tract are mucus and ciliated epithelium absent? Is it the terminal bronchioles, the tertiary bronchi, the alveoli, the primary bronchi, or the bronchioles? So this one is actually pretty easy if you think about it logically. So in your airway, you have these goblet cells, and these are found like amongst the epithelial cells. You've got the epithelial cells here, goblet cells here, then epithelial. They're a lot less common. These produce mucin, and that is a key component of mucus production. You do also have submucosal glands, or seromucous glands, which you don't have in the diagram, and both of these together serve to produce mucus, which traps and removes inhaled particles, pathogens, bacteria, anything that's in your upper respiratory tract that really shouldn't be there. So this gets moved up by the cilia. It like drags it along until it ends up away from your airway. So it's pretty important that these structures are present in almost all of your airways. Otherwise, stuff's going to get stuck in there and you're not going to be able to get rid of it. The one exception to this is the alveoli. And we kind of talked about this last time with the fact that you need surfactant around here anyway. So in order for gaseous exchange to rapidly occur between the air in the alveoli and then the blood in your vascular system, the lining needs to be extremely thin. If you start putting mucus and ciliated epithelium in the alveoli, it's going to increase the total distance oxygen needs to travel to be assimilated into your body, or conversely for carbon dioxide to go into the air to be released out of the body. So that is the only area that you're not going to have these two, giving us the correct answer of click it. Yeah, the correct answer of alveoli. Right, question 24. So lung function tests such as spirometry measure lung function using specifically named volumes or capacities. What is the name given to the volume of air contained in the respiratory tract under normal circumstances at the beginning of inspiration? Is it the residual volume, the functional residual capacity, the inspiratory reserve volume, the expiratory reserve volume, or the tidal volume? So in order to understand this, we have to look at lung volumes and capacities. And this is something that my good friend Holly really struggles with. Sorry to call you out, Holly. But helping her through this also helped me realize that visualizing this is the best way to wrap one's head around it. It can get a little bit confusing because there's so many different terms that are essentially just a combination of different terms, when in reality there's only 4 different volumes we need to know about. So yellow, white, blue and green, and then everything else is just a combination of those. And I think that's where it can get a little bit confusing. So when we're breathing in and out normally along here at the white line, this is our tidal volume, and this is the volume of air we are breathing in and out most of the time. So if I just stop and take, just breathing like that, sorry for the ASMR, that's our tidal volume, just the normal breathing we have. Now, if at the end of a breathe out, so we breathe out, then we suddenly breathe in very deeply, and we fill our lungs as much as we can, the extra air we've just breathed in, this yellow part, is our inspiratory reserve volume. So this extra capacity, so this is the extra capacity that our lungs can take in if we need them to. And then at this point, our lungs are filled with as much oxygen as possible. And this total volume of air is known as the total lung capacity. Now, go back to like tidal volume, or if you want, from we fully breathed in. If we now breathe out normally, like normally would, so just, it's now going to be down here. So on the cusp between the white part and the blue part. So that's normally where we're at. But we can find if you breathe out, you can then breathe out a little bit more. So you can then breathe more out. We can like force it out. And if we breathe this extra air out until we can breathe out no longer, this volume of air is known as the expiratory reserve volume. So the tidal volume combined with the inspiratory reserve volume and the expiratory reserve volume makes up the vital capacity. This is the amount of air that we can breathe in and out of the lungs in total. And you might also note, voice break again, you might also notice that there is a small volume of air down here that never leaves our lungs, and this is known as the residual volume. This air doesn't ever leave our lungs because if it did, our lungs would become a complete vacuum and would collapse in on themselves, and we would die. Painfully, I might add. So with all of that, let's have a look at this question. What is the volume of air contained at the start of inspiration? So this is the start of breathing in normally, so we can assume that this is just after breathing out. So around this, between the white line and the blue mark. So this point here at the bottom of the graph oscillations, the amount of air that's in our lungs is going to be everything below this value. So this is going to be the expiratory reserve volume and the residual volume, which combined makes the functional residual capacity. So the correct answer to this question is the functional residual capacity. And we'll be coming back to this graph anyway, because this is something you kind of need to just wrap your head around. If you can memorize this, quite a lot of respiratory you'll get along just fine with. But we're definitely going to come across it. Oh, I've thought ahead. I've already put it to the next one. Right, question 25. Which of the following descriptions regarding tidal volume is correct? So tidal volume of a healthy man is approximately 800 milliliters. Tidal volume is difficult to be measured by using a simple spirometer. Rate of breathing affects tidal volume, but the depth of breathing does not. Tidal volume is the volume of air that can be forcefully inhaled after a quiet exhalation, or tidal volume is the ideal volume of air delivered by a mechanical ventilator in one respiratory cycle. So let's have a little look at a spirometer, shall we? So a spirometer is one of these things. So you have the patient and they breathe into this device and they are watched over by this technician, denoted by a lady with judgment in her eyes and a resting bitch face. She's clearly enjoying her day. And so the patient will breathe in normally at first to develop a baseline level. So you can see on the graph here, this is the baseline level. You just breathe in and out normally to get this, essentially to make the tidal volume. And then afterwards, they're asked to breathe in deeply and then blow out as hard as possible. So this is this line going up and then all of the way down. And this is normally done several times. I think usually the standard is a best of 3 is taken. Sometimes if you're checking asthma, for instance, a patient will do it 3 times, take their inhaler, wait a short while, and then do the test, usually after 30 minutes, something like that, and come back to see if there's been any significant change. So when you use this device, you then get a result that looks a little bit like this. Now, from these values, we can then start to predict, or at least give an idea of certain pathologies. In particular, it helps us know if a patient is suffering from restrictive or obstructive form of disease. So it's a useful diagnostic tool. And we get that from the plateau graph that we make. So with this, let's just sort of go through some of the potential answers it could be. So a tidal volume of a healthy man is approximately 800 milliliters. This is incorrect. In fact, here we go. This is wonderful. I love this. It shows the different tidal volumes. You have it all color coded at the bottom. Take a screenshot. Put this in your notes. So, tidal volume of a healthy man is approximately 800 milliliters. This is incorrect. The normal tidal volume of a healthy man is about 500 milliliters. So bigger men, if you get the Mountain from Game of Thrones, they can have a larger capacity. And then smaller men like Demetrius Johnson is probably going to have, I say that he's an athlete, he's probably still got huge lungs. But on average, smaller men are going to have smaller. But about 500 milliliters, that's the average for most men. So the second one is tidal volume is difficult to be measured by using a simple spirometer. Not at all. I mean, that's why we get the baseline values. A spirometer is used to help us predict this oscillation. So if the patient breathes normally first to get this baseline level before breathing in and out as hard as they can, we're going to get the tidal volume. So obviously the spirometer is good at measuring this. Next we have the rate of breathing affects tidal volume, but the depth of breathing does not. No, sorry. Kind of the opposite way around. So it doesn't matter if you're breathing normally or if you're going really quick. This volume of air doesn't change. I mean, if you're breathing more rapidly, it can lead to hyperventilation. There's less time for gaseous exchange. You can get certain pathologies because of that. But tidal volume is only measuring how much air is going in and out, not how much is being assimilated into the body. So how fast you're breathing does not affect it at all. So next we have tidal volume is the volume of air that can be forcefully inhaled after a quiet exhalation. No, this would be the tidal volume and the inspiratory volume together, and that would make up the inspiratory capacity. So not that one. So we can rule, I should have been crossing these off, it went long really, shouldn't I? So we can rule that one out, which gives us our correct answer. Tidal volume is the volume of air that can be forcefully inhaled after quiet exhalation. No, that's not right. Where was it? Tidal volume is the ideal volume of air delivered by a mechanical ventilator in one respiratory cycle. This is correct. So I've got too many images for this one. Right. So you might have seen this in a lot of medical programs. If you're a medical student or a nursing student, or if you've been to hospital, you might have seen this actually used in real life. So the point of a mechanical ventilator is to stimulate normal breathing. And this is meant to allow a patient to resume normal tidal volume breathing. So ideally, a mechanical ventilator should only deliver an individual's tidal volume in one respiratory cycle, because if you start delivering more, you are going to, like, if you have overventilation, you can cause barotrauma, you can hurt the patient. So it's very important to deliver that around 500 milliliters per patient, as we saw here, around 500 mils. So, oh my God, so many diagrams. So yeah, that's a bit of a weird one. I remember doing this with my friend and they got completely caught out by this. But also because it's just, we were quite early on in the course and we didn't even know what a mechanical ventilator was. We hadn't seen one yet. But yeah, that would be the correct answer. Okay, question 26. Which of the following statements best describes the pathophysiology of a reduced forced vital capacity in a patient with kyphoscoliosis? So the abnormal curvature of the spine causes premature closure of the airways during expiration. The abnormal curvature of the spine increases chest wall compliance during inspiration. Abnormal curvature of the spine reduces chest wall compliance during inspiration. Abnormal curvature of the spine causes smaller airway obstruction, or the abnormal curvature of the spine causes air entrapment of the lungs. So this is a diagram of kyphoscoliosis, and it's a condition characterized by, well, you can see abnormal curvature of the spine, and this can lead to certain restrictive lung diseases. So in kyphoscoliosis, not to be confused with normal scoliosis, and because the spine can be curved forward, and this is the kyphosis, and to the side, which is scoliosis. So you combine those two and you get this kind of almost corkscrew type spine. And this results in a reduction in the ability of the chest wall to expand properly during inspiration. As a result, this leads to reduced compliance. I've just given away the answer, haven't I? The reduced chest wall compliance makes it more difficult for the patient to take deep breaths and fully expand their lungs during inspiration, leading to a reduced forced vital capacity. So yeah, okay, I've kind of given away. So the abnormal curvature of the spine causes premature closure of airways. Nope, it does not cause any premature closing. It doesn't force anything closed like that. That's just not correct. The abnormal curvature of the spine increases chest wall compliance during inspiration. Nope, because, well, that would probably be a good thing in certain situations, and that's because it does the opposite. The abnormal curvature of the spine reduces chest wall compliance during inspiration, and it's during inspiration specifically. In case there's another question, kyphoscoliosis only affects it during inspiration. That's the important part. So it's not. So the abnormal curvature of the spine causes smaller airway obstructions. Nope. It affects it through restrictive mechanisms, which reduce lung volume due to altered chest wall mechanics. It does not typically, there's some rare cases, but typically it doesn't result in airway obstruction, which would be more characteristic of an obstructive lung disease. You know, think like asthma or chronic bronchitis. When you have kyphoscoliosis, you want to think more restrictive, not obstructive. And so the abnormal curvature of the spine can cause air entrapment in the lungs. So while it can affect lung function, it doesn't typically lead to air entrapment in the lungs. Air trapping is more commonly associated with conditions such as chronic obstructive pulmonary disease, COPD, so chronic bronchitis and emphysema. So number 3. Okay, question 27. Which of the following statements correctly represents the underlying pathophysiology of chronic bronchitis? Irreversible scarring of pulmonary connective tissue due to chronic inflammation. Permanent dilation of bronchi and bronchioles secondary to chronic infections. Reversible chronic airway inflammation due to bronchial hyperresponsiveness in response to allergens, abnormal irreversible enlargement of the alveoli due to alveolar wall destruction, or chronic exposure to smoking or air pollutants causing mucus hypersecretion in the bronchi. So we looked a little bit at chronic bronchitis in the first question, so hopefully you remember what it is. This isn't just completely out of the blue. So chronic bronchitis leads to inflammation of the bronchioles and excess mucus production. So let's just kind of go through those questions one by one, and I'll leave this diagram up so you can kind of think about it as we go through it. So irreversible scarring of pulmonary connective tissue due to chronic inflammation. This is the pathophysiology of interstitial lung disease, which is characterized by chronic immune response against inhaled dust particles, and that's what results in this irreversible scarring of pulmonary connective tissue or pulmonary fibrosis, not chronic bronchitis. Permanent dilation of bronchi and bronchioles secondary to chronic infections. So this is the pathophysiology of bronchiectasis, in which necrotizing infections cause destruction of muscles and elastic tissues, particularly in the bronchi and the bronchioles. That leads to airway destruction, permanent bronchial dilations, that kind of thing. So bronchiectasis is a chronic condition characterized by abnormal and irreversible widening, inflammation, and damage. Usually it's the larger airways in the lungs. This condition, yes, leads to a buildup of mucus and recurrent respiratory infections. Over time, the walls of the bronchial tubes, they become thickened and scarred, impairing their ability to clear mucus effectively. So there is a little bit of overlap between them, but chronic bronchitis, see, I've just done it now. Bronchiectasis is more to do with infections. So bronchiectasis, think more infections in line. So number 3, reversible chronic airway inflammation due to bronchial hyperresponsiveness in response to allergens. So chronic inflammation is a part of chronic bronchitis, but this answer mentions nothing of the extra mucus production, which is the primary characteristic of chronic bronchitis. So number 3 up here, this one is actually a better explanation of asthma. The fact that it's reversible inflammation. So we can rule those two out. So number 4, abnormal irreversible enlargement of the alveoli due to alveolar wall destruction. This is one of the COPD diseases. So it's in the same category as chronic bronchitis. This, if you remember earlier, this is the definition of emphysema, which once again leaves us with just one correct answer. So chronic exposure to smoking or air pollutants cause mucus hypersecretion in the bronchi, and that is our correct answer. So in chronic bronchitis, chronic exposure to noxious particles, particularly like smoking, maybe air pollutants if you live in quite a busy city, that leads to mucus gland hyperplasia. So that's having more mucus glands, increased number of mucus glands, and goblet cell metaplasia. So other cells are transformed into goblet cells, and because you have both of these around, you then start to get excess mucus production, this hyper secretion in the large and small bronchi. So that is the correct answer. Question 28. A 17-year-old teenage boy presented acutely to the emergency department with drowsiness, slurred speech, pinpoint pupils, and a reduced respiratory rate after a party. Naughty boy. A pulse oximeter was attached, which showed an oxygen saturation of 89%. For those of you not familiar, we normally want to see 97% and above, usually 98%, depending on who teaches you, if there's no other underlying pathophysiology. So which of the following, so yeah, 89% is very low. So which of the following is the best investigation to diagnose a suspected type 2 respiratory failure? So first of all, we need to know what the difference between type 1 and type 2 respiratory failure is. So type 1 and type 2 are both conditions that result in inadequate gas exchange in the lungs, but they differ in their underlying mechanisms and clinical presentations. So type 1 respiratory failure is also known as hypoxemic respiratory failure and is characterized by low oxygen levels in the blood, so hypoxemia, with normal or low arterial carbon dioxide levels, so normocapnia or hypocapnia. So to answer this question, we need, well, if we had this patient, we would need to know whether the patient has a low oxygen saturation because they are not taking enough oxygen in, or because they are not releasing enough carbon dioxide. And so to figure this out, we're going to need to do one of these, which again, I don't know how to build it up more. It gives the answer away. This is an arterial blood gas measure. So in the case of the vignette with this boy here, this is a typical presentation of respiratory depression secondary to opioid overdose. Arterial blood gas is the most accurate investigation in measuring the partial pressure of oxygen and carbon dioxide in the arterial blood, as well as blood pH level. So in order to diagnose a patient with a type 2 respiratory failure, the CO2 level needs to be greater than 6 kilopascals, while the partial pressure of oxygen needs to be less than 8 kilopascals. The exact measurements might differ a little bit depending on what kind of measurements you're using. So if you're using millimoles per mercury, CO2 would need to be greater than 45, and from the diagnosis we have here, 8 kilopascals would have to be less than 60, although from the diagram we have it says less than 80. So again, certain hospitals might do things a little bit differently. Just make sure you check with wherever you're doing it. But this is the mark scheme I've got for this question. I don't know what country this question's from, so just bear that in mind. But we'll just go through kind of the concepts with it. So why is it not these other ones? So venous blood gas. So venous blood gas measures the partial pressure of oxygen and carbon dioxide in the venous blood, so not the arterial. This cannot be used to diagnose type 2 respiratory failure, as the oxygen and carbon dioxide levels in the arterial and venous blood have just huge differences. I mean, one's oxygenated, one isn't. So venous blood is deoxygenated, so it's just, you can't use it. You can't use venous blood gas to figure this one out. Chest X-ray. Chest X-ray is like more used for diagnosing pathologies. Maybe you have pneumonia or something like that. It's not going to tell you anything about type 2 respiratory failure, as it gives no information about the partial pressure of oxygen or carbon dioxide. So again, if you suspect some kind of infection, yes, go for a chest X-ray. But if you think type 1 or type 2 respiratory failure, not going to help you. Spirometry. So spirometry, as we saw earlier, measures the lung volumes and capacities. It's not useful for diagnosing type 2 respiratory failure, as it gives no information about the partial pressure of oxygen and carbon dioxide in arterial blood. You're noticing a pattern here. Do these tell us about partial pressure of oxygen and CO2? If not, it's not going to be that. And then peak flow. Peak flow measures the volume of air that can be forcefully expired, and it is useful for monitoring asthma and measuring the severity of certain asthma exacerbations. Again, you know the drill. It's not going to help us with type 2. It doesn't tell us anything about oxygen and carbon dioxide, so it's not that. So the correct answer is arterial blood gas and ABG, and this is why you'll see these routinely done at hospitals. Question 29. After 24 hours of labour, a 26-week gestation neonate is transferred to neonatal intensive care unit because of concerns about his breathing. He is grunting and has nasal flaring with subcostal recessions and peripheral cyanosis, so that's kind of blue around the lips. He has oxygen saturation of 82%, again very low, and a respiratory rate of 80 breaths per minute, very elevated. He is treated with tracheal installation of surfactant, which the following explains the physiology behind this treatment. So we kind of covered this a little bit before with last episode. If you didn't watch that, then we'll just go through it again. So let's have a little look at one of our alveoli, shall we? So you have this surfactant around the inside of the alveoli. So surfactant is an amphiphilic phospholipid. So the hydrophilic head inserts itself into the lining of the alveoli wall, whilst the hydrophobic tail moves out towards the airspace. The compliance of the lung is the volume of air that the lung will inflate under a given pressure. So the greater the compliance of the lung, the less work of breathing is required for adequate ventilation. Alveoli are filled with fluid, and the attraction between the adjacent water molecules in this fluid is known as the van der Waals forces. Chemists rejoice. I'm sure you're probably sick of hearing about van der Waals forces. This causes an increase in surface tension, which leads to the alveoli collapsing. So the collapsed alveoli results in decreased pulmonary compliance, and so more work of breathing is required for ventilation, leading to respiratory distress. Surfactant disrupts the van der Waals forces and reduces surface tension, therefore increasing lung compliance and assisting the newborn here in question to breathe. So surfactant increases the respiratory rate to increase minute ventilation. The minute ventilation refers to the volume of air entering and leaving the lungs in a certain period, and this is dependent on lung volume and respiratory rate. Administering surfactant will increase the minute volume by increasing the volume and compliance of the lung, but it has no effect on the respiratory rate. So yes, it increases the minute ventilation. It does not affect the respiratory rate in any way, shape or form. So surfactant stimulates gaseous exchange in the anatomical dead space. So anatomical dead space refers to the volume of air in the conducting zone. So think the nose, like the larynx, the pharynx. Those are areas where no gas exchange is able to take place. The role of surfactant is to decrease that surface tension in the alveoli, which increases lung compliance. By decreasing alveolar collapse, surfactant aids that gaseous exchange in the lung. However, no gas exchange takes place in the anatomical dead space. That's why it's the anatomical dead space. No gas exchange takes place. So it's not going to be number 2. So surfactant decreases the surface tension of the alveoli to decrease lung compliance. No, it increases lung compliance. That's its whole purpose. So again, it is the opposite. It doesn't decrease lung compliance. It increases lung compliance. And then just the last one, surfactant decreases the surface tension of the alveoli to decrease lung elasticity. So we talked about this a little bit before. Elasticity of the lungs is inversely related to compliance, and it measures the lung's ability to rebound after expansion. So the greater the elasticity of the lung, the more able it is to hold volume for longer periods. So surfactant does not affect this. Right, fantastic. Last question. Thank you for sticking with me. A 22-year-old man is brought to the emergency department because he is feeling dizzy and lightheaded. An arterial blood class is performed on arrival and he is diagnosed with a panic attack. Which of the following ABG results would you expect to see? Back to arterial blood gas. Now, there's a little trick, a little mnemonic I have found that helps me to answer these types of questions. So this is cadet face right. And literally every time I come across anything like this, that goes straight off in my head. So this relates to the oxygen hemoglobin dissociation curve. So this graph illustrates the relationship between the partial pressure of oxygen in arterial blood and the saturation of hemoglobin with oxygen. And this helps us to understand how changes in oxygen tension affect the binding and release of oxygen by hemoglobin. So cadet refers to carbon dioxide acidosis, 2,3 DPG, and exercise and temperature, which here they've just put temp because they kind of assume they're two separate things, but they are very closely linked. So just because I spent most of my first year wondering what the hell 2,3-DBG is, 2,3-DBG is 2,3-diphosphoglycerate, and that's a small molecule found in red blood cells, so the erythrocytes, and that helps play a crucial role in regulating oxygen transport and delivery in the body. You honestly don't really need to know more about this. You just know that this is something that is used by red blood cells. So given this graph, and we have cadet face right in our head, let's think logically about what happens when someone is suffering from a panic attack. So during a panic attack, you hyperventilate, you start panicking, and this leads to an increase in the respiratory rate and the depth, and that causes a decrease in the partial pressure of carbon dioxide in arterial blood. I kind of like to think of it as an increase in breathing rate means that you're blowing off more carbon dioxide. So from cadet face right, we know high levels of carbon dioxide is linked with acidosis, so think what would happen in the opposite case. A decrease in the partial pressure of CO2 is going to result in respiratory alkalosis. So in response to respiratory alkalosis, the kidneys will then initiate compensatory mechanisms to help restore this acid-base balance. One of these mechanisms involves the excretion of bicarbonate ions into the urine. The kidneys excrete bicarbonate ions to decrease the overall bicarbonate concentration in the blood, which helps to counteract the alkalotic state induced by hyperventilation. As a result, bicarbonate levels in the blood usually decrease during a panic attack due to urinary excretion as part of this compensatory response to the respiratory alkalosis. So with all of that in mind, let's go through each of these in turn. So decreased pH, decreased carbon dioxide, decreased bicarbonate. So although hyperventilation during a panic attack would cause a decrease in arterial carbon dioxide, you would expect this to cause alkalosis. What we see here is metabolic acidosis. So it's not this one. Decreased pH, increased carbon dioxide, increased bicarbonate. Again, this is respiratory acidosis, which is typically caused by obstructive lung diseases. Panic attack is going to cause alkalosis due to the high levels of carbon dioxide that are exhaled during hyperventilation. So not this. Normal ABG. I mean, I'll just hazard a guess whether you think this one is right. So, I mean, after you've stopped panicking, yes, you'd expect it to go back to normal, but during the panic attack, it's just no. No, so I'm sorry, I can't even, no. Okay, increased pH, increased carbon dioxide, increased bicarbonate. This is metabolic alkalosis. So with the, this is metabolic alkalosis. So this is, no. I need to actually start writing a script out before I do these. My brain just decides. Right, anyway, last one. Increased pH, decreased carbon dioxide, decreased bicarbonate. This is the correct answer if you haven't figured it out from the other ones being ruled out. So carbon dioxide dissociates in the blood into carbonic acid and H+ ions and is responsible for making the blood more acidic. During a panic attack, patients they will hyperventilate and exhale this excess level of CO2. So the lack of acid causes the blood pH to rise into an alkaline state. The kidneys detect the alkaline state and start to secrete bicarbonate into the urine in exchange for H+ ions to try and increase the blood pH back to its neutral level. Therefore, because of the panic attack, you expect to see a decreased carbon dioxide, decreased bicarbonate, and subsequently a raised pH. So that's all from me. Hopefully this has been helpful. I think next video we'll probably do cardio. Next. Thank you for watching. Hope you learned something. Drop a comment if there's anything you're unclear of, if I didn't explain anything properly, if I've got something wrong. I make mistakes, and I will try and get back to you. But I hope this has been helpful, and I will speak to you guys next time.